The topic of my speech is the role of hematopoietic stem cell transplantation in pediatric lymphoma in the era of immunotherapy. Thank you, organizers, for asking me with this speech. Pediatric lymphomas are curable in the majority of patients, but relapses and refractory disease still occur in significant number of patients, up to 25% in some cases, for example, in anaplastic large cell lymphoma. Immunotherapy and target therapy improved outcome in adults with relapsed and refractory Hodgkin lymphoma, but data in children are limited. In general, prognosis in RR non-Hodgkin lymphoma is unfavorable, probably except anaplastic large cell lymphoma, ALK positive, and peripheral and primary medicinal B-cell lymphoma. Development of immunotherapy and target therapy may improve outcome in definite non-Hodgkin lymphoma subtypes, especially CAR-T therapy for B-cell lymphomas, pembrolizumab for primary medicinal cell lymphoma, crizotinib for anaplastic large cell lymphoma. But what is the role of hematopoietic stem cell transplantation in pediatric lymphoma in the context of new treatment options? Generally, relapsed and refractory lymphomas are treated with second-line polychemotherapy, except diffuse large B-cell lymphoma, in which probably CAR-T therapy is more appropriate now. But in children, other types of B-cell lymphomas are still cured and treated with second-line polychemotherapy. In case of remission, still hematopoietic stem cell transplantation is a choice for consolidation. But if there is no remission, then we use third-line therapy, target therapy, immunotherapy, and even, of course, palliative therapy if we don't see any success. In our institution, we treated 172 children with RR lymphomas. It is rather a big number because we know well that these patients are rare in general. Among them, Hodgkin lymphoma were 90% children, and non-Hodgkin lymphoma 82 children. Other lymphomas were typical for pediatric group, with the majority B-cell neoplasms, 47 children, if we speak about non-Hodgkin lymphomas. This summarizing slide summarizes children with Hodgkin and non-Hodgkin lymphoma. It is usually not done because it's not very correct, but still you can see this overall number of patients, and this slide demonstrates that it's very important to continue observation for patients even 10 years after treatment, 10 years after transplantation, because you see that overall survival decreases and how it happened with our patients. And you see that one of our patients developed chronic GvHD of lungs, and he died more than 10 years after transplantation, and it is shown here on this slide. Overall, children with Hodgkin lymphoma, even in case of relapse and refractory disease, still have, in general, good prognosis, favorable prognosis, because you see that in our group of patients, 73% of children were alive even more than 10 years after treatment. But the children with non-Hodgkin lymphoma still have suboptimal or even unfavorable prognosis, despite modern treatment. We use in our children polychemotherapy, such treatment options as brentuximab vedotin, immune checkpoint inhibitors, and transplantation, autologous and allogeneic. Unfortunately, still we have no opportunity to perform CAR-T cell therapy, but I hope that with time these option also will be in our hands. You see that the majority of our children were treated with platinum-containing regimens for second-line polychemotherapy, and almost 57% of them responded to therapy. But the group of patients that received brentuximab vedotin still in children is limited, and you see the main publications, and they are mostly concentrated on overall response, which is well, but data on long-term progression-free survival is limited to small reports. Our data show that still brentuximab vedotin, at least in Hodgkin lymphoma, is not a game changer. Yes, our patients were very treated prior to brentuximab vedotin. They received median number of prior therapy lines of 4, and after brentuximab vedotin, progression-free survival was only 24%, but the majority of children responded to this treatment. Allogenic and autologous transplantations didn't significantly improve outcome of these children after brentuximab vedotin, but still it is an option which can be used with some success. Complications is important thing after target therapy. We observed polyneuropathy, herpes zoster, and one patient demonstrated anaphylactic shock, but in general, this treatment was well tolerated and was performed even in outpatient department. Immune checkpoint inhibitors is another important immunotherapy, which is extensively used in Hodgkin lymphoma, especially in adults. Now, more and more data continue to emerge in children, but still all data in children are limited to data with a small period of observation. We performed this treatment in 36 children with relapsed and refractory Hodgkin lymphoma. Response was achieved in 83% in the majority of patients. But the same as in adults, we demonstrated a very good overall survival, in long-term overall survival, but the majority of patients, especially those that were not consolidated with, for example, our transplantation, relapsed. Data in children and non-Hodgkin lymphoma are even very limited, so they are limited to some case reports or small pilot studies, but they demonstrated as in adults that some types of non-Hodgkin lymphoma, such as primary mediastinal large B-cell lymphoma and extranodal NKT cell lymphoma, can be sensitive to this treatment. We used immune checkpoint inhibitors in 11 children with non-Hodgkin lymphoma, and we demonstrated response in these clinical settings, which I previously called. So we used immune checkpoint inhibitors in 11 children, and the response was observed in 4 of them with primary mediastinal large B-cell lymphoma and peripheral T-cell lymphomas, as was anticipated. And in all these children, we consolidated treatment with transplantation, allogenic or autologous, and still we observe them in long-lasting remission.
Sorry, we have to interrupt you again because, okay, no, go ahead.
Thank you.
Yeah.
You see these slides which demonstrate that patients with non-Hodgkin lymphoma, which usually earlier received only palliative treatment in case of refractory and relapsed course of the disease, so they didn't respond to second-line therapy. And now, in this case, they responded and even demonstrated some survival. Of course, adverse effects of immune checkpoint inhibitors is also an important question, especially in children. Though well tolerated in the majority of children, we saw some serious side effects, among them tuberculosis in one patient, colitis in one patient, and pneumonitis that led to death of the patient in one case. So it is a serious treatment also. We should remember it. What is about autologous transplantation in pediatric Hodgkin lymphoma? So in general, this type of treatment is also well known for doctors, but still we may say that this option leads only to approximately 50–60% of long-term overall survival if we look 10 years or more on these patients. In case of treatment of patients with relapsed and refractory non-Hodgkin lymphoma, the data are even worse. The majority of patients die, and only 20–30% of patients can be cured, even still. Here you see our data on autologous transplantation in relapsed refractory Hodgkin lymphoma. We demonstrated data which are usually demonstrated by other experts. So very important is to achieve remission prior to autologous transplantation, and in this case 72% of children demonstrated long-term progression-free survival in our case. A very important slide, to my opinion, because we are talking now about transplantation and immunotherapy, and so we saw that if we use autologous transplantation in children after previous exposure to immune checkpoint inhibitors, then these children have long-lasting remissions. Unfortunately, the median follow-up is only 1 year, but still this is data that make us very optimistic for this treatment. Non-Hodgkin lymphoma and autologous hematopoietic stem transplantation is also a well-known strategy for treatment. In our case, we demonstrated rather a high level of overall and progression-free survival for this group of patients, but it can be explained in our case because 1/3 of patients that were transplanted had primary mediastinal large B-cell lymphoma, and almost 20% anaplastic large cell lymphoma alpha positive, which in general have a better prognosis than other types of non-Hodgkin lymphoma. Plus, we didn't perform second biopsy in the majority of patients, so we could overtreat some patients. This data demonstrate our results of autologous hematopoietic stem transplantations in children with primary mediastinal large B-cell lymphoma, which are also rather optimistic. Another interesting data on relapsed and refractory anaplastic large cell lymphoma, alpha positive. We treated 7 children, and all of them are alive. We used transplantation, allogenic and autologous in patients, cratotonib, rituximab vedotin, and also this type of lymphoma is characterized by the fact that transplantation can be administered even in active disease, and it is well established fact. And we showed, and we have an experience when we cured a girl which was transplanted in active disease. Now she is free of disease and alive for more than 2 years. And probably the allogenic transplantation is more effective in this type of lymphoma because progression-free survival is higher. But still, we think that autologous transplantation also may be used because of lower rate of transplant-related mortality. Lymphoblastic lymphoma and allogenic transplantation is also a type of lymphoma which should be transplanted if we achieve remission. Usually patients not in remission are not transplanted, but we have unique experience. We transplanted 7 patients in active disease, and still 3 of them are alive with long follow-up. But in general, of course, these patients should be transplanted. Our data are show that half of patients can be treated in case of lymphoblastic lymphoma and allogeneic transplantation. These data are similar to world data. Hodgkin lymphoma and allogeneic transplantation is a unique entity. Usually, few centers in the world have an experience of this type of transplantation. In case of, that you see this data that the first table shows data from the whole Europe for almost 20 years. This data collect only 91 children. So, and we collected 15 patients. I think it is a big result. The majority of patients were in remission. We used in the majority immunotherapy, nivolumab or rituximab vedotin or their combinations, and used post-transplant cyclophosphamide for GVHD prophylaxis. The data are usual. Nearly half of patients were cured with this approach, but what is important is that we got a high incidence of GVHD, the same as in adults, and this GVHD led to the to death, and this GVHD was steroid refractory in the majority of situations. So this data allow us to make some conclusions. Hematopoietic stem cell transplantation remains an important option for the treatment of pediatric relapsing refractory lymphomas even in the era of immunotherapy. Hematopoietic stem cell transplantation is still a standard treatment for remission consolidation after second-line therapy in pediatric Hodgkin and non-Hodgkin lymphoma, except diffuse large B-cell lymphoma, where probably CAR T-cell therapy is more appropriate. Autologous hematopoietic stem cell transplantation after immune checkpoint inhibitors in Hodgkin lymphoma demonstrates promising results, and allogeneic transplantation after checkpoint inhibitors in children is associated with high incidence of GVHD. I want to thank all my colleagues from Raisa Gorbachev Institute, Pavlov University. Thank you for your attention.